Welcome everyone, and thank you for joining us today for CareJourney's webinar, How to Evaluate Provider Performance. We are going to go over a few housekeeping items before we get started. We will be emailing you the recording as well as the slides from today's webinars. All attendees should expect to get that this week, so keep a lookout for an email with a link from us. We will have a Q&A session towards the end, so please hold your questions till then. You can send us your questions via the chat feature at the bottom right of your screen. And you can just simply send the chat to the host or all panelists, and we will be able to answer your questions in the order we receive them. We have muted all participants at this time just to make sure there's no background noise. But again, if you have any questions or comments, just send them via the chat feature. And with that, I would like to actually welcome our speaker today, Anish Chopra. Anish is the president of CareJourney and was the first CTO under President Obama. He is a fervent proponent of increasing public and private sector collaboration for advancing value-based care through data and analytics. Welcome, Anish.
Thank you, Deepika, and thank you all for joining today. We're going to have a bit of a longer presentation to share the context and the circumstances under which we believe now is the time for the community to come together in harnessing all of this data that's been made available to help understand high value and challenging areas where we are performing lower than expected so that the country as a whole can make material progress. To do that, I'm going to do a little bit of introduction on the front end about CareJourney and then hopefully dive right into the purpose of today's call, and with a little bit of time left for some conversation, as we're hopeful this is the beginning of a dialogue and not nearly the end. A little bit of CareJourney. We've been around for about 4 years, and we've been honored to serve a number of leading organizations across the payer community, the provider community, ACOs, and some tech firms and others, largely around the proposition that we should be harnessing as much of the openly available data, especially data made available by CMS, to help inform a move to value-based care from whatever lens or perspective you're operating in. We are today focusing on a new generation of capabilities that build on the progress of what we've already launched. First and foremost, we've been assisting organizations build, manage, and optimize their networks through a program we call Network Advantage. We are, for those organizations interested in running the same library of insights that we perform at the national level, at the patient-specific level, we provide individual insights, first through our Population Insights program, and now, of late, through the CMS Blue Button Initiative. We partner with app developers who help make consumers, physicians, and ACOs make better use of Blue Button data. And soon we'll be launching an initiative to better understand cohorts of patients. So much of this is about groups of individuals that have common clinical challenges that today navigate in a far different manner through the healthcare delivery system. And our goal is to identify and root out some of those areas of variation. So with that as a backdrop, here is the agenda for the discussion that we're about to have. What I'd like to do is make the broad case for why we should collaborate as a community on a transparent and hopefully trusted provider rating system. I want to share a bit about what I believe the key attributes of such a system might look like and why the time is right today for us to get to work on this important endeavor. We'll be introducing more formally the CareJourney Index, the basis of today's discussion. We'll call that our deposit, our initial deposit on what we consider to be a multi-year journey. We'll obviously describe a bit about how organizations we envision using the index, and then most importantly, how our membership model is all about engaging you in the development and deployment of it in the years to come. So let's start with a little bit of context. For those of you on the line that I've not had the pleasure of meeting, during my time as President Obama's Chief Technology Officer, I had 3 primary responsibilities as it related to healthcare delivery reform. The first and foremost was that we make government data publicly accessible for commercial use. And that meant in the healthcare domain specifically, finding ways to bring the healthcare databases in Medicare and Medicaid specifically available for public use. In addition, we looked at making sure the healthcare system could operate in a more consistent and common manner, an interoperable system where health information at health system A or with health plan B might be shared to advance the health needs of patient C. And last but not least, to make sure that we could identify all of the areas in which our healthcare system could wring out incentive models or other means to drive higher value performance. Why is this needed? Because both political parties agreed at the outset of this debate on healthcare reform that regardless of the political dimensions of access expansion, we need the country's healthcare inflation rate to move to GDP plus 0 if we're going to unlock as much value as we can to whether it be on certain political sides of the aisle, investments in climate change or in income inequality, and others might pursue other areas such as tax cuts, that we need to find a way to get healthcare down to some constraint on inflation. There is a growing coalition of stakeholders, and I hope many of you on this call are in that coalition, who believe that we can actually accomplish this goal by delivering better care that naturally result in lower cost. And that the thesis for this coalition is that if we opened up as much of the data as possible, we can tap into the expertise of the country, individual doctors, patient groups, health plan leaders, to surface and hopefully scale that which seems to work, and that we would use transparency and payment model incentives to drive and reward better behavior. That's the goal. And if we go into where we are as a country, I guess the headline is we're still under construction. It is the case that we've made material progress. In fact, just today or yesterday, CMS announced record savings on the 2018 cohort of Medicare ACOs. Further progress that we have a lot to celebrate, but we know we have a lot more work to do. Under construction is the notion that we have to bring about a more transparent system, whether for consumers to take direct action or organizations consumers trust to help them navigate, to steer away from lower value services and providers and towards those that have had a history of delivering higher value. And if the country moved collectively towards the higher value service providers, it might raise performance as a whole and help us achieve that objective. Now, one of the challenges and why this is so hard is that, and the reason it's under construction, is that for so many, in order to understand how well we're doing, we need access to the underlying information, and that information is often not transparent. Data held by individual plans or providers often are used to grade performance for internal purposes, sometimes publicly shared, but mostly internally shared. And there's not a lot of transparency as to the underlying data systems, or if I would say breadth of data access on which to run those numbers. Medicare and Medicaid have been much more transparent. Anyone can access the underlying data, but increasingly Medicare and Medicaid outsource to a number of stakeholders that are contracted to develop cost and outcomes measures. A bit of a challenge if you're trying to reconstruct those measures or to improve upon them in your own environment. And then last but not least, we obviously understand the world of social media. The traditional consumer sites have obviously engaged in this subject with 5-star ratings powered by Yelp reviews and the like. Again, not a lot of access to the underlying data, but certainly a little clearer on the algorithms they use, individuals that actually type in their scores. So our goal today is to pursue opportunities that lie at the intersection of these two really important endeavors, that we build a more transparent measurement system, algorithmic transparency, on a larger and open database that can be replicated and built upon and expanded upon throughout the country. We can do this on account of a number of factors. Number one, this, by the way, this is context. Transparency is important, but it is not sufficient in explaining why we've not had the kind of performance measurement systems that we need. It's not just about the underlying data model or the method, but it's also about how granular the information is, how wide our cohorts look in terms of benchmarks and comparators, how reliable the scientific methods were in developing the measures, how recent the information is. I mean, I know we're obviously in a CMS environment looking at 2-year-old data for hospital star ratings as an example. Has the algorithm or the methodology been evaluated or been embraced in some form or fashion by those to whom it is meant to measure? And how frequently do we see feedback in terms of this is a better way or an alternative method for achieving the same goal? How do we create a community where this happens at a much faster pace to not only deliver that trusted, transparent rating system, but to do so consistent with the values that we see listed on this chart? Our opinion is that an improved rating system, taking advantage of all of the information that's been made available and all the algorithms that can be reproduced in a public domain, that this system would benefit all stakeholders interested in the move to value. Health plans constantly evaluate networks. Even if they have larger, wider networks, they often build shadow or narrower networks to drive people towards the higher value performing providers within the network. Health systems are obviously trying to figure out ways in which they can improve the performance of the networks they've established or to recruit or expand the networks into new markets. Physicians clearly want to understand their performance, and if there's more transparency in the underlying methodology, then they have a clearer path to the actions necessary to be a higher value performer. And ideally, we need to live in a world where consumers have more informed access to the information about how and where to seek care. Throughout this presentation, I'm going to be referencing back a number of specific use cases, but it's important to understand everyone in the move to value would benefit from a trusted, transparent provider rating system. Now, why is the time right for this system to be built today? We've already mentioned the fact that getting to GDP plus 0 is a national imperative. The reality is that healthcare inflation continues to rise faster than we would have otherwise liked, and frankly, faster than we would have modeled in a world where we were moving to value on a faster pace. The good news is, especially with the shot in the arm, with the results published yesterday from CMS, we hope to see continued growth in the ACO model. So organizations that are built for purpose to drive value can thrive in the operating environment in which they find themselves. But we also acknowledge that we still live in a world post Atul Gawande's cost conundrum on McAllen, post the Dartmouth Atlas historical research on variation, that even to this day, we have in every community in the country widespread variation in risk-adjusted per capita costs that we know, if we can find a way to wring out through better care delivery, will result in that GDP plus 0 goal for the country. This is a long-range journey, and we believe it's best to start with cost, even though we understand that outcomes, patient satisfaction, and provider adequacy are really important factors in a truly trusted and transparent system. Starting with cost is clearly an economic imperative, and thankfully built on data sets that are more widely accessible with math that can be run in order to perform the kind of analyses that we're describing. We'll talk a bit about the total cost of care and our approach to episodes in a moment, but it is important to note in every one of these vectors, we anticipate making progress in parallel, not sequential. So while we're focusing today's discussion on cost as the logical starting point, we are launching as well an initial take on outcomes, and we hope both cost and outcomes will improve over time as we think about methods of capturing better the patient sentiment and understandings about provider adequacy and more appropriate provider-to-provider benchmarking. The remainder of our discussion will fall under the following approach. Number one, I want to make sure you understand the data sets that I've alluded to thus far. Then we'll talk a bit about the specifics on how we've constructed the episodes in our current iteration of CareJourney Index, how we've thought about attribution, how we estimated the observed expenditures against the alternative, and how we think about benchmarking and ratings. The outcome of all of this is the CareJourney Index that you'll be learning about this afternoon. So we'll come back to this framework, but I would like to dive right in on the beginning part of this, which is the opportunity to describe the robust data that CMS has made publicly available. Today, by researcher license, CMS has made available all Medicare fee-for-service data and Medicare Advantage encounters data for one calendar year, 2015. We expect later this year or early next for CMS to release Medicaid encounters data, built on a standardized data model that we had worked on early in the Obama administration. Today, in CareJourney's hands, we have over 10 years of fee-for-service history and that 1 year of MA encounters. That is a cumulative summary of around 80 million beneficiaries, over 10 billion claims, and evaluations, or I should say content, if you will, on over 2 million providers, again, cumulative over the years. One of the clear advantages of CMS is that the data is linked longitudinally. That means we understand individuals who flip from fee-for-service to MA or MA back to fee-for-service, and we're able to stitch together their story, their health status, their improvement, the degree to which they've had higher value or lower value episodes of care. CMS has also made available line-level detail, which allows one to construct more granular profiles. All of the measures, most of the measures that CMS publishes are auditable, and they are accessible for third-party use, and they are and they are also obviously standardized. There have been decades of researchers who've been involved in making sure that this content is accessible and usable. But this is the more important point as to why now. The volume of data Medicare has released allows us to reduce the inaccuracy or misclassification rate on any given measure because we have a higher volume of material on which to run the math. This is a critical factor and one of the biggest reasons why we applaud CMS's continued moves to add publicly available data, and frankly, why we applaud the still in Congress bipartisan cost legislation that called for national APCDs with the same spirit of openness, so we can understand on larger samples the kind of ratings that we need to drive value. In the area of episodes, what I thought we might do is start with the primary care, total cost of care discussion, and then move to specialists. We made the judgment that the CPC Plus program allowed us for a more accurate way of measuring total cost of care for primary care doctors. So we've extended the logic that CMS applies for this specific care model that's in practice at around 2,500 sites and scaling by 2020, thanks to Primary Care First, which is the next iteration. And we've applied that logic to every primary care doctor in the country and built a total cost of care model tied to that attribution logic. On the specialist side, we have begun the journey of designing clear episodes of care as the foundation. Now, it's important to note that in this area, there are a number of options on how we would have developed said attribution, or I should say assign the cost of an episode. We chose to adopt a simple framework that says we're going to link over time based on a certain trigger event, a set of activities. Some of them are clearly articulated, and we'll get to in a moment, areas like BPCI Advanced or those that are tied to the MSPB logic. But increasingly, we are also working with our members to find new models. The premise is that for specialist ratings, it is critical to associate longitudinal episode profiles in order to associate high or low value, at least as to the relationship of cost. Here you can see a simple example The individual encounters that have been made publicly available since 2014 tell you some perspective about in-office billings for any individual physician. And on the specialist side, that may only tell you a partial story. The patient's journey under their care in terms of how they were cared for, whether they went to skilled nursing facilities, did they have follow-up care, was there a readmission, all of those capabilities in the context of a patient's episode, critical in that part of the cost structure. It is insufficient, however, to use today's narrow set of episodes to score every doctor in the country. So we are pleased and honored to be a part of an open source movement that began with its origins in 2010. In the ACA, the provision of the law focused on releasing Medicare data specifically called for Medicare data to be made available for performance measurement and explicitly directed CMS to procure a model, an episode grouper model that would allow for the construction of more granular and transparent means of measuring total cost of care and hopefully outcomes around the Medicare beneficiary. In 2012, CMS conducted that RFP and had 4 finalists. The Lewin program tied to the Optum team and Thomson with Truven, IBM, 3M had a team, and a team from Brandeis, sort of an academic institution in the mix of a sea of private sector enterprises, came forward with a model that was actually quite refreshing in the sense that it was built on a complete open source foundation. The Brandeis prototype was launched and published shortly thereafter was the formal episode grouper for Medicare as commissioned and funded by CMS to the tune of tens of millions of dollars. That system, I'm pleased to say, is expected to be made publicly available later this year or early next through a program called PACES. Under the leadership of Brandeis and a number of other stakeholders, CareJourney is honored to be on the team to help bring that open source grouper to life and have committed to ensure that we have a much more transparent and customizable framework for developing episodes for purposes of total cost of care and outcomes measurement. This is an exciting decade of change, but only now we're seeing the benefits in the form of the new capabilities. That means we have data sets that are commercially available, free of intellectual property constraint, and we'll have episode grouper logic that is similarly free of intellectual property constraint, both available for the American people and those of us on this call, those who are committed to move to value, work together on figuring out the right areas to source out variation and to identify high and low value performance. These are really exciting times. I can't do the PACES model justice, but I thought I'd share an example of the type of analyses that they've run to associate not just a single doctor to a single episode, but a true care team involved in diagnosis, procedure, the chemotherapy, and active monitoring. And it is important to know that these episodes allow us to organize through what we would consider more consumer-friendly methods of the concerns and needs they have and the manner in which the system should treat them. This is an exciting endeavor, and I hope all of us will stay tuned and celebrate as that progress moves forward. So that covers a little bit of the current state, which is we understand the world that we're in. We today operate mostly on Medicare fee-for-service data, and we're able to compute episodes at the MSPB layer for every DRG and these bundles that have been built for BPCI Advanced. But we know where we're heading. We're going to be adding Medicaid encounters as CMS releases it later this week, and we are looking forward to incorporating the PACES algorithm into the CareJourney Index, obviously with full member input as we do with all of our programs. All right, I'm going to continue down this road probably for another 10 minutes, maybe 15, and then I want to make sure that we have time for conversation about how this might affect where you're going, feedback you'd have, concerns, and so forth. Now, if you have data that's broad enough for the math, and you have the episode group or logic that's transparent and trusted, then we have another opportunity when it comes to attribution to ensure that we can ensure that a score of someone's performance is really about their involvement and not aggregated at the layer of a group or a system that may not reflect their individual contribution to the rating. So many organizations today have shared with us provider rating systems that have aggregate performance metrics. Hey, your physician group is high or low relative to an average. Well, that may be fine, but individual doctors within the group have just as much, if not more, variation. So we think that the critical value here is the ability to attribute cost and outcomes measures to the individual doctors or care teams at a layer more granular than traditional groups or systems. That's really important if we're going to try to figure out how we can make the system better, as opposed to using a punitive measure that just sort of penalizes organizations for what we do. It would be a failure on our part if we wouldn't acknowledge the most important challenge in any of these mathematical models, and that is, how do you adjust for risk? Now, herein lies a number of areas where we want to just spend a few minutes to go a little bit deeper. First and foremost, there is the underlying question about provider practice. That's the variable we're trying to isolate. And we understand that that today is often masked in patient complexity. How do we take the complexity out of the equation in measuring individual provider performance? Well, today, we've made the judgment that we should normalize patient complexity on over 100 variables by age, by sex, by comorbidities, by socioeconomic status, and the like. And that we apply these risk adjustment models, not in a gross, abstract manner by simply normalizing an HCC score, but rather to be very granular at every scored episode to risk adjust on the variables that matter, so that we can isolate provider practice as the rationale for the variation, and to strip away that which we deem to be a source due to the complexity of the patient. This is clearly an area that will continue to be refined with member input, but our initial stake in the ground was to make sure we identified individual procedures, individual episodes, identified the risk of the patient in those episodes, and aggregated and grouped provider scores tied to those episodes when coming up with their overall score. And you'll see more of that as we come to the end. Benchmarking and ratings. One of the areas in which we intend to be quite active within the membership, and again, it's one of the benefits of having access to the national files, is that we don't rely on a small number of members to share their individual data on which we can provide benchmarks. We have the opportunity to benchmarks across a large number of networks, basically every provider, every network, every facility in the country. What's important to note here is that in this particular example, you're seeing a graphic that shares with you the following. What was the difference in performance on total cost of care spend by primary care doctors in any given geographic region? In this case, we've used the Census Bureau's statistical region, CBSAs. How can we track markets in the country where the performance for the best performing doctors, the fives, in relation to the ones, those that we tagged as being the underperformers? How might we describe the variation in a given region? How far off are the higher performers from the lower performers on total cost of care? The key factor for us, and you'll see this in the way we've presented our material, is that we've attempted to index providers not only amongst themselves, i.e. their specialty, but to do so within their geographic region and explicitly on how we measured the observed costs that that were incurred against the expected based on the risk adjustment formula. It is that difference between the provider's observed costs and their expected costs across that geographic region that forms the basis of these benchmarks. Now, it's interesting to note where in the country have we found the highest variation from the best performers to the lowest performers. To think that that may be a market for value-based care to scale a bit faster. There's a lot of room for improvement. In comparison to those where we see lower variation, the band of difference in performance between the highest and the lowest is much narrower. And so this is, again, the spirit and the principle of the benchmarking and ratings capability. So obviously this gives us a higher level view. We'd want to drill down at the individual physician level. And this is a sample. I've named this Dr. Anish just to make sure that we're not revealing any individual doctors' names, but this is the type of scorecard that we've assembled for each and every provider in the country that bills Medicare. You can see that Dr. Anish is an orthopedic surgeon in the DC area. We happen to be in Arlington, Virginia, for those who know where CareJourney is headquartered. You can see how much CMS has paid them, how many patients they've treated, how often do they see those patients. And you can see the episode types that we're breaking down the scorecard for Dr. Anish. Dr. Anish has performed a number of major hip and knee replacement surgeries, has done them without the joint treatment, has done the major reattachment of limbs. And you can see as we go across the dashboard, if you will, this physician is deemed slightly lower performing, so just below market average, and has a higher than expected volume of knees and hips, but slightly more expensive on those procedures, especially the hip and knee procedures outside of joints. Much higher as a fact against their expected. You can see on the far right our CareJourney average observed to expected ratio on where Dr. Anish is an outlier. And again, this reflects longitudinal expense, not just the procedure that we're talking about. Not to beat the dead horse of the concept, but you can see the same application, another specialist, the same doctor, Dr. Anish, that doctor's talented, practicing orthopedic surgery and endocrinology at the same time. Same market, slightly different profile, much higher patient panel, not enrolled in an alternative payment model, is among the lower performing on the scoring systems. And you can see the episodes that were attributed to Dr. Anish, the endocrinologist. Hypothyroidism, benign prostatic hyperplasia, chronic kidney disease. You can see this doctor has a lot of chronic kidney disease patients. And so again, in each of these areas, we are able to identify their observed costs, the costs that we see by CMS, against their expected costs based on our risk adjustment formula. And you can see this particular doctor, by a factor of 2, 3, up to 5 times, had the observed costs relative to what we expected based on patient's condition and everything else. And again, the spirit here is the more granular, the more transparent, the opportunity to get a little bit deeper into where and how we can improve. You can see this aggregated up. Benchmarking and ratings can be used at the individual doctor level, at the regional level, and we can see them even at the ACO level or clinical network level. ACO networks are public by CMS, so we can simulate network-wide performance measures, and we're using real data, but we've blinded the ACOs on whether or not in the same geographic region, they've had a care team that has a lower CareJourney index score than another. In this particular market, you can see a $500 PMPY delta between those whose care team averages a 3 versus those whose care team averages a 2. That just gives you a window of the opportunity when thinking about how your networks are scoring, being able to grade your networks in geography as opposed to just looking at the individual doctors one by one. We estimate that moving a care team 1 index point from a 3 to a 4, from a 2 to a 3, on a population of 10,000 patients would translate into $4 million in savings. Again, in the spirit of where we're going on the ACO journey, huge opportunity to build out and improve upon our network performance. So now we're going to wrap up. So we've reserved some of this time, may actually get through this in a timely manner so that we can actually organize some conversations, start thinking about the questions you want to ask. I'm going to bring us home now on the next few graphics just to sort of outline what we are doing and how we're expecting to have impact in the membership. We view the CareJourney Index as having an opportunity for involvement all the way from the I'm curious phase to I'm all in phase, and I want to drive referral patterns as a result. We think the I'm curious phase is where many organizations are starting. CareJourney Curious. We're going into the inform model, where the goal is to figure out how do we see ourselves. We've been looking at our own performance for years. We know how we're doing. We feel pretty confident that we're doing reasonably well against expectations or not, and you know it. How does accessing the CareJourney Index help to just ground swell, if you will, ground truth, how we're doing against our peers? So giving you a window beyond the four walls in which you operate today. That then, we believe, will migrate towards organizations that are willing to start benchmarking or comparing their highest performers and to begin to either disseminate directly or indirectly through training programs the sort of variation that we're seeing that might be candidates for a dedicated initiative. We do have members that have contemplated incentives to reward organizations that get to better networks. This is particularly interesting amongst organizations that have access to wide networks, where technically speaking, the patient can go anywhere, but that the accountable care teams, the at-risk specialists, that they have some motivation, if you will, to route patients down the chain to care teams, specialists, and others that have higher performing indices. And then obviously, in my ideal world, not just for internal use, i.e. physician referrals, but for consumer-facing opportunities, this whole idea of a referral check, which think of it as a spell check for referrals, where I can gauge whether or not the individual doctor with whom I'm visiting has alternative physicians that may be in a better performing category that are available for my referral. We see that as a kind of a more mature implementation of the model, and something that we hope networks may do internally when they track their referral management, but also the growing number of consumer-facing apps may incorporate this information to inform those decisions. We obviously are quite motivated to get started, if you will. This journey is this is not an academic presentation. We're not here to suggest that we wish to do this. We are launching this conversation on the foundation of over 800,000 ratings that we've made available to doctors across the country that are in the Medicare fee-for-service database. The indices that we're publishing today, the cost and outcomes indices, are powered, as we mentioned earlier, on all the core methods that CMS has already embraced and are public and open, or measures that are widely accessible, like the Choosing Wisely measures. We acknowledge that these scores, or we hope or aspire that this version that we are launching today does reflect the variation that is within the provider's control, that we are built on these openly available algorithms, and that we drill all the way down to the NPI level as we covered throughout this presentation. We have members today who are just getting started on the CareJourney Index use cases, but on the health system and provider side, it's often a vehicle for, so I should say on the health plan side, on network development, entering new markets or contemplating new products within markets. It's a vehicle for provider contracting. So when you're negotiating with a 3 or a 2, you might change your negotiating posture relative to a 4 or a 5. We absolutely believe there are opportunities to think about patient-facing provider directories. Those are not live in any of our members yet, but we hope that members will contemplate doing so. and that we obviously see organizations use them to route individuals towards a higher value, even if it's a sub-network within a broader network. On the provider side, definite interest in benchmarking and performance improvement. It's critical to understand the drivers of why some are an X and others are a Y, or in our case, 1 through 5. But being able to point to individual granular episode-specific detail does allow the conversation to go beyond the granular, or the generic, I should say, aggregated number. And on the patient side, we do dream for a world. We are working with a number of Blue Button app developers, but we are eager to see a world where patients are equipped with the information they need to make smarter decisions about the specialists and primary care doctors that they trust to care for their needs. So that gets us right to the 15-minute mark. What I'd like to do is now share a little bit about how we intend to engage our members in this journey. For those of you who are new to CareJourney, we follow the principle of membership and collaboration. Our members are involved in the development of these indices. Our members are involved in modifications or improvements. We obviously engage our members every quarter in figuring out higher value additions, new opportunities to measure performance, new algorithms to refine the models we've already launched. We intend to add more specialty-specific metrics. Obviously, it's important to do so, not just not just on the models that we've outlined at the NPI level, but start thinking about feedback to practice groups. And all of this needs to be much more actionable. So what can I do as a physician to move from a 2 to a 3, or a network administrator to move my network from a 2.2 to a 2.8 or a 3.1? All of this is part and parcel of our membership model. Our spirit here is collaboration. Anything we do for one member is available to all members on the data that we present to them, because we run it on the same CMS data model. We value member-to-member collaboration to give us sometimes a tough feedback that we may have gotten the math wrong, or positive input on how we can move forward to address some of the lingering issues, whether it be in risk adjustment or in attribution. Obviously, for members, for folks on the line today, we understand it's mostly going to be kind of I wouldn't call it a one-way, but a presentation by me, and we'll get a bit of a Q&A going. But if any of you have interest to go deep, we'd love to schedule calls, visits. You can send us an email at info@carejourney.com, and I want to spend as much time as I can with members to dive into this. I am, just to kind of route out the formal introduction of this whole model, I spent the last 5 years working as hard as I can to get the underlying databases public and to make the interoperability systems in our country more internet friendly and just part of the foundation. Now that we've made material progress on raw data access and interoperability, I'm turning the bulk of my time and energy on getting this right. So I'm really hopeful you'll join in the journey or give us feedback and be a part of this in some form or fashion. And with that, Deepika, I'll turn it to you and engage in any conversation on next steps.
Thank you, Anish. We did get a few questions via the chat, so I'm just going to start in the order they were received. One of the questions we got was, was from Ryan. Thank you, Ryan, for sending the question. He says that I see the press release and I like the idea. Where can I view the CJ index scores for my PCPs and my organization? For sure, Ryan.
I mean, that's basically, the sort of the idea of a membership model. Obviously, CareJourney members can look it up today for any doctor in the country. And obviously, we'd love to involve you in some way, shape, or form, and we'd be happy to connect you to the right folks. But that is the spirit of this. Today, our members are logging in and accessing this service now.
Thank you. A follow-up question from Ryan was about, we agree that cost alone may not tell the full story. I'm sorry. Without the knowledge of outcomes, it could be dangerous to incentivize and about patients. For example, imagine a low-cost provider that has a much higher patient mortality rate than peers. Is it ethically justifiable to steer patients based on cost alone? And Anish, if you want to talk about, this is obviously, we said cost is a starting point, but obviously we're looking at outcomes as
absolutely
well.
Yeah, Ryan, no, it is not a good idea to route people on cost alone. I simply shared where we are on the journey. Our outcomes measures are published, but they today reflect really modest, relatively easy to understand and run methodologies around avoidable admissions, avoidable ER visits, the choosing wisely measures. Those are where we've started. Risk-adjusted mortality is a critical factor and obviously high on the list to work on. So Ryan, that is exactly right. And that is exactly why this is a multi-year journey.
Thank you, Anish. Another question is, if I was a CareJourney member, how would I receive this data, and how often is that data and the scores updated?
CMS publishes quarterly updates on fee-for-service data in roughly 6 to 8 month lags. So in CareJourney's hands today, as it is for others who are involved in the CMS research license, we have data through Q1 of 2019. Our teams then process that data on the algorithms that we've been coding up over the prior quarters and make that accessible to members via a Tableau dashboard. And they can log in and access the information directly without having to do much of any additional work. We obviously have member services staff who communicate with members frequently and take a lot of questions back about, can I cut it this way? And I'm curious about that. And I'd like to see it in this scenario. And so it's very important to organize the model that way. So that's that is the how on the access part. What other questions might we see?
Yes, we have a comment and a question from Frank Pelka.
Hey, my man! We got to unmute you, brother. What's the question, Frank? Where are we? Go ahead.
So the question, thank you for sending it via chat and the comment. I'm going to read the comment first. The cost elements of the index seem well-baked. Quality improvement, and safety are crucial if together with cost you wish to express value. Diabetes is a highly variable disease. Patient compliance is variable. How to define quality depends on many aspects of clinical data to enhance the index.
Yeah. Oh man, Frank, this is you're by the way, for folks on the line, Frank is a hero to many of us in this sort of open movement, and is I would argue one of the lead instigators of this PACES episode ecosystem. So Frank, on behalf of the country, thank you, sir, for what you've done. On this important question of clinical data, absolutely. Part of the reason why I've put so much time and energy on interoperability is that we begin to standardize clinical values that can be incorporated into quality measurement. In fact, I know, Frank, you and I have talked about this before. For those of you on this line, the next chapter of interoperability is to feed clinical quality registries. On Thursday, I'll be visiting HHS, sharing a few words about work that they're doing on social determinants of health and the PCORI network. And I'll also be Thursday visiting with the ASCO and the team at MITRE on oncology, focusing on the ability for new FHIR-based interoperability standards called M-Code to feed quality registries. And of course, Frank, we can't wait to FHIR enable the ACS registries. And hopefully, as that process is underway, there can be mechanisms by which that data can be combined on cost and outcomes to help us refine these models. So yes, Frank, as all these comments indicate, please don't suggest that this is mission accomplished and we're done. Go forth and engage. This is an initial deposit on a multi-year journey to think through. But the question is, you got to start somewhere. So this is our first start. So thank you, Frank. Any other questions or feedback?
Yes, we do have a question on the episode methodology. How does the episode methodology that you're using account for physicians that cover different types of surgeries? For example, a surgeon that does hip versus knees. Is there a case mix adjustment?
That's a great question. That's a judgment that I think merits member feedback. Our thesis in version 1 was that we wanted to address like-for-like procedures and to risk adjust at the procedure level, and then to aggregate. So Dr. Anish, who you recall from the slides, represented a doctor that had a bit more of knee replacements than others. And there may be another doctor that skews a bit more towards hand surgeries. And so we wanted to make sure that we ran observed to expected calculations at that DRG or episode or APC level, and then aggregated that by doctor to assess their score. So we were not comparing a hand surgeon to a spine surgeon under the category of neurosurgery or orthopedic surgery. We were using that to construct the individual score against their peers, adjusted for what we expected that case to otherwise have been. Great question.
All right, we have a couple more questions from Jenna. Thank you, Jenna, for sending the question. Do future visions consider in taking other claims information in addition to CMS for an insurance company to compare CMS versus custom claims data?
Yeah, no, Jenna, thank you very much. First of all, point of personal disclosure, I serve on the board of Healthcare Cost Institute. That was the aggregation of Aetna, United, and Humana data. In that example, sadly, United is pulled out, but the opportunity to aggregate claims data in the commercial environment is absolutely critical. We have payer members and have begun conversations about whether they want to load their environment as an addition to the CMS data to get more refined measures. We are very interested in that. We want to do so in a manner that would benefit the broader membership as opposed to a one-off to an individual customer, but we understand the sensitivities of this data, so we're open to those conversations. But it is critical, in my view, that we do have more transparency across all payers, and then we add in, to Frank's comment, the EHR data, and obviously some of the other factors like quality registry information, and frankly, even some of the social determinants information, given the comment I just made about Thursday, where we start to standardize patients that have a certain amount of social need as another factor in measuring the observed to the expected. So yes, we have a lot of interest in marrying payer data to this. CMS's decision to make Medicaid managed care available gets us some of the way there, and Medicare Advantage data is already in our hands. So we do have some non-CMS supplied, but rather CMS regulated data, and we hope to go more broadly in the commercial domain.
Thank you, Anish. And one more question. This one is, could you talk about the risk adjustment formula just a bit more? What does it include?
Yeah, so that's a great question. I will, if I did want to bring in a colleague to run a little bit deeper, I could ask Chris to come over and do a little bit more on the granular definitions of the risk adjustment formula. This is Chris Freider, everybody. Hi, Chris.
Hi. So yeah, we base it off the MSPB methodology. If you look at their open methodology, which we can send out as well, they have a substantial list of, there's like 100 covariates that go into the model, including HCC scores, patient demographics such as age, gender, enrollment status, and things like that go into the model. We also include in the model dummy variables for the different type of episodes that would make sure we're adjusting specifically for those episodes. So we do that at each specialty level and each episode type level. So there are numerous different models run. So to make sure that the episodes are adjusted accordingly.
Obviously, members, this is a huge area of debate and discussion. Attribution and risk adjustment are central to the math, and clearly not Moses tablets to say CareJourney figured everything out. We want to do this with you, and we'll start with what is in the public domain. We got time for a few more questions. If we can keep going, happen to go.
I have another question on peerless specialists. How do you handle peerless specialists who are doing something that no one else does?
This came up in another conversation, and that is what an awesome subject. So, in fact, just yesterday, I was visiting our member UPMC in Pittsburgh. By the way, I went to the Steeler game last night. It was quite an amazing thrill, so thank you for that. But it was Dr. Peel at UPMC who raised the question as to whether or not there's a mechanism for addressing specialists that are in this unique category. Obviously, that is, today we don't have a solution for this, but it is critical that we identify a provider directory should reflect the talents of the physicians that are performing and the care team that are performing. And so the ability of organizing like for like groups is a very important thing more broadly. On the other hand, rare diseases are so important to tackle that it may be that there are only 1 or 2 doctors in a given region that even treat patients of this type. So we're working with members to try to think about a classification taxonomy for physicians that reflects the people they treat and the work that they do above and beyond the self-reported specialty designation as available through, for example, CMS. And so that is an important question, and it is critical that we, as a country, get better on making sure that patients are matched to the right providers so they get the best possible care.
And I think we have time for just one last question, which is, how can we use this data to guide our conversations with our providers?
Look, for obvious reasons, this is going to be a work in progress. So we're on the inform side of the journey, and not on the, to the ethical question that Frank raised about routing people to low-cost doctors that have a higher risk-adjusted mortality rate. So what I would suggest to you is that an obvious starting point is to begin identifying in aggregate where your challenges are, where your variation exists within a clinical network, to identify the cohort of physicians that you might want to engage to root out some of that variation, and you'd put your time and energy on the variation that has the highest impact on your achieving some kind of total cost of care metric. And so that whole iteration of, we operate in this market, in this community, this is what the disease burden looks like in our neighborhood, this is how we've cared for these folks, this is how we benchmark against our peers, and in these areas, these 3 areas, we see both a challenge for us and variation in the market, so we'd love to engage. And that may inform clinical interventions that you may not be deploying today, but are specifically tied to the challenges at hand. We recommend this be part of a broader chief medical officer dialogue around performance improvement. For obvious short-term reasons, people are building networks, so you might want to use this to inform physicians in your network about how they compare with peers in the network. And again, life is about 3 things: carrots, sticks, and transparency. And so some of you may choose the transparency path, some might provide incentives to refer people towards higher value specialists, and some of you may offer some kind of penalty. And all of that, I think, is member-led and member-driven. We want to largely just help support you on the math.
Thank you, Anish, and we're almost up on time. So for any questions that were not answered, we will get back to you after this webinar. Thank you so much for all the questions and the comments that you sent. I do want to say thank you one more time for listening in to all attendees, and thank you to Anish for walking us through this. Again, I would mention that if you want to request a one-on-one deeper dive and a one-on-one conversation with Anish, just email us at info@carejourney.com, and we will coordinate a conversation. We will be sending you, like I said at the beginning of this webinar, we will be sending you the recording and the slides later this week, so keep a lookout for an email from us. Once again, thank you everyone for joining, and we hope to see you in our future webinars. Thank you.
Bye, everyone.